Okay, we're going to talk about the respiratory system and answer the questions. What is the pleura? What roles do lungs, airways, and alveoli play with O2 and CO2 exchange? What is the vascular and lymphatic supply? And what muscles and nerves fine-tune breathing? Hello, everyone. My name is Dr. Morton, and I'm the noted anatomist. To begin, your brain can survive weeks without food and days without water, but only minutes without air. Why? Our cells need a constant supply of ATP. ATP is produced through oxidative phosphorylation. Think Krebs cycle and electron transport chain. That takes place in our mitochondria. We put O2 and glucose in one end, and you get CO2 and ATP out the other. Without O2, oxidative phosphorylation stops, and very little ATP is produced. Without ATP, high energy organs, think brain and heart, pun intended, begin to fail within minutes. Without eliminating CO2, acid-base problems rapidly occur. In a nutshell, oxygen must be brought into the body and CO2 must be eliminated from the body. And how do we accomplish these vital tasks? Shing! The respiratory system. And we do so through the following components of the respiratory system. Let's begin with pleura. The pleura is a double-layered serous membrane. And here in this illustration, the outside layer is the parietal pleura. It lines the inside wall of the thoracic cavity. The visceral pleura lines the outside surface of the lung. The space in between is called the pleural space, and it's filled with pleural fluid. The analogy that's often used is a fist in the side of a water balloon, where the fist is the lung and the parietal pleura is the outside of the balloon and the visceral pleura is the part of the balloon that's surrounding the hand or the fist. The space in between, the pleural space. Parietal and visceral pleura are continuous at the root of the lung. This is the pulmonary ligament when we look at this medial view. Pleural and serous fluid lubricates lungs for breathing. As we inhale, the parietal and visceral pleura rub along each other, but the pleural fluid reduces friction. The pleura is lined by mesothelium. If we just take a little outline of the parietal pleura, that's mesothelium, or visceral pleura, that's mesothelium as well. And each pleural sac is separate. The right pleural sac is not continuous with the left pleural sac, so they do not communicate. Infection in the right pleural sac does not go into the left. Let's talk a little bit more about parietal pleura. And so in orange is the visceral pleura, and in blue is the parietal pleura, and it lines the wall. And there are four regions based on location. Costal pleura lines the inside of the ribs. Costal means ribs. Diaphragmatic pleura, the top of the diaphragm. Mediastinal pleura, by the mediastinum. And cervical pleura, or cupula, goes up above the first rib into the neck region. In this illustration, you can see the apex of the lung where the cervical pleura goes up. It's right by the subclavian artery and vein just above rib 1. So a PICC line, if it punctures the subclavian vein, it can cause a pneumothorax. The costophrenic recess is located at the lung base. It's a space at the junction of the costal and diaphragmatic pleura. That's why it's also called the costodiaphragmatic recess. It allows lung expansion during deep respiration, like this, like that. It's also a site for pleural fluid accumulation, or an effusion. In this normal chest x-ray, there are the ribs and there are the two hemidiaphragms. And that sharp angle is the costophrenic recess. They call it an angle in a chest x-ray because you don't see the whole recess. Now in this patient, look at that costophrenic angle. It's sharp. But on the other side, there's a blunting or obscuring of the costophrenic angle. That is the meniscus sign. It indicates a pleural effusion, excess pleural fluid in the pleural space, often seen when the patient's upright. Visceral pleura lines the lung. It follows the contour of the lobes in the lungs, and especially at fissures. It forms the shiny outer surface. And if you grab forceps, you cannot pull it or tease it apart from the lung. It's intimately associated, and so you see this in this micrograph, mesothelium and some loose connective tissue. The pleural space is filled with pleural fluid, and it has a pleural pressure that we call an intrapleural pressure, abbreviated as big P pressure, little I, little p, intrapleural. It is -5 centimeters of water. Now, it's negative relative to atmospheric and alveolar pressures. Atmospheric pressure is measured as big P atmosphere of 0. It's actually not 0. The barometer measures it at 760 millimeters of mercury at sea level. But to help us get the concept, we typically just say, well, it's 0 relative to intrapleural pressure. Alveolar pressure is big P, big A. It's 0 when your glottis is open. Atmospheric and alveolar pressure equalize. So when we say intrapleural pressure is negative, it's always in relation to atmospheric and or alveolar pressure. What function does the negative intrapleural pressure serve? The subatmospheric intrapleural pressure keep the lungs vacuumed, sucked up to the diaphragm and chest wall. So when the diaphragm contracts or the chest wall expands, the lungs expand with it. This is negative pressure ventilation. This negative intrapleural pressure also keep the lungs from collapsing when you exhale. So the lungs go to collapse because there's a tendency for the lungs to collapse because of the elastic tissue, but the negative intrapleural pressure keep them sucked up against the chest wall and diaphragm. Here's a question. What happens if intrapleural pressure becomes equalized with atmospheric pressure? The answer is a pneumothorax. If intrapleural pressure is -5 and atmospheric pressure is 0, and we take some sharp object and puncture the chest wall and introduce an opening, then air moves in and equalizes intrapleural pressure with atmospheric pressure, and shing, the lung collapses, the chest wall expands, and we get air in the thorax, pneumo-air thorax. In this chest x-ray, look at this patient's right lung. There are normal lung markings. There's wisps of white, almost looks like snow inside there. That's cartilage and blood vessels. But look at the patient's left lung. That's a pneumothorax. It's void of normal lung markings between the chest wall and the visceral pleural line on the collapsed lung. If you look closely, there's increased space between the rib, the intercostal space, because of the expanding chest wall. Next are lungs and airways. The lungs are paired organs of respiration. They occupy most of the volume of the thoracic cavity. Their function is to bring air into contact with blood. The right lung has 3 lobes, superior, middle, and inferior lobes, separated by 2 fissures. The oblique fissure separating middle and inferior lobes, and horizontal fissure separating superior and middle lobes. The superior lobe is also called the right upper lobe, right middle lobe, and inferior right lower lobe. And those abbreviations you're going to see all the time. Why do we only see a little bit of the right lower lobe? To answer that question, let's take a look at a medial view of the right lung with its anterior and posterior surfaces indicated. As we said, there are 3 lobes, superior, middle, and inferior, separated by 2 fissures, the oblique fissure and horizontal fissure. That superior lobe, or right upper lobe, forms the most anterior and superior region of the right lung. It's above the horizontal fissure. The inferior lobe, or right lower lobe, forms most of the posterior part of that right lung and the inferior region that sits on the base, or not sitting, but near the base and the top of the diaphragm. It's below the oblique fissure. The right middle lobe forms the anterior and inferior region of the right lung, and it's between both fissures. When you now look at an anterior view of the right lung, observe the middle lobe obscures the view of the inferior lobe. It's standing in front of it. So this might be begging the question, why is he spending time on this? To answer the question, let's look at the same anatomy in chest x-rays. The left picture shows a PA view and the right picture a lateral view. In brown, there's the right upper lobe with the horizontal fissure below it. There's the right middle lobe, and the picture on the right, you can see horizontal and oblique fissures. And then there in purple is the right lower lobe. Notice in the PA view, we just see a little bit of the right lower lobe, though it goes all the way up that high. Like, take a look at the lateral view. That top arrow on the right is showing how high up that right lower lobe goes. But you only see on a PA that much because the right middle lobe obscures its view. Horizontal fissure separates right upper and right middle lobe. Oblique fissure separates right middle from right lower lobes. Hey, I thought you were going to tell me why I should care about this. Here is a chest x-ray. Which lobe has a consolidation? So as you're looking at this chest x-ray, right and left lung, you're like, well, that looks like a snowstorm. That's a consolidation. But is that in the right middle lobe or the right lower lobe? And to answer that question, we need the lateral chest x-ray. So when we now look at the lateral view, like, look at that white, the consolidation. I keep saying snowstorm. That's not very clinical, is it? But that consolidation, that's on top of part of that cardiac shadow, and it's above the oblique fissure. That's a right middle lobe consolidation. Let's do another one. In this chest x-ray, where's the consolidation? Well, there it is. There's the white stuff. There's the snowstorm. But is that in the right middle lobe or right lower lobe? To answer the question, we need a lateral view. And if we look over, look at the consolidation is obscuring the view of the lumbar vertebrae, and it's inferior to the oblique fissure. That's a right lower lobe consolidation. A lateral chest x-ray is needed to distinguish right middle from right lower lobe consolidation because their opacities overlap on the frontal view, but are separated by the oblique fissure visible only in the lateral projection. Next is the left lung that has two lobes, a superior and inferior lobe, separated by one oblique fissure. The cardiac notch is on the superior lobe where the heart nestles in there, and at the bottom of that is the lingula, part of the superior lobe. The superior lobe is also called the left upper lobe and inferior left lower lobe. Let's look at a medial view of this. There are two lobes, the superior lobe or left upper lobe and inferior lobe, left lower lobe, separated by one fissure, the oblique fissure. There's the cardiac notch in the lingula as well. If we now look at an anterior view of the left lung, notice a similar thing. Much of the left upper lobe obscures the anatomy of the left lower lobe when looking at it from the front. And so in these two chest x-rays, there is the left upper lobe in yellow, or lemon, if you will. Notice you see most of in the left part of this chest x-ray is the left upper lobe that you see. And the left lower lobe, it forms most of the posterior region. You just see a little bit in the bottom, but a lot of it, you see most of the volume of it's in the back. And so you see that the left upper and left lower lobes are separated by the oblique fissure. Let's do this again. Now, which lobe has the consolidation? Well, there's the consolidation. There's the white snowstorm stuff. Is that left upper lobe or left lower lobe? We need the lateral view because when we look over, it's above the oblique fissure. That's a left upper lobe consolidation. How about this one? Which lobe has a consolidation there? Well, there's the white stuff. Is that left upper or left lower lobe? We take a look at the lateral view. There's all the white stuff. It's below the oblique fissure. That's a left lower lobe consolidation. And that are the lungs and lobes in a nutshell. So if that's a lung and that's a lobe, then we see that lobes are further subdivided into segments that are called bronchopulmonary segments, a subdivision of a lobe supplied by its own pulmonary artery, tertiary bronchus, and lymphatics, separated by connective tissue septae that enable them to be a surgical subunit of a lobe. You can cut one bronchopulmonary segment of a lobe and leave the other ones functioning. In the right upper lobe, there's an apical, a posterior, and an anterior bronchopulmonary segments. In fact, each of the lobes have their own bronchopulmonary segments with their own names that I'm not going to cover each of the names. Airways. They branch repeatedly and produce progressively smaller conduits. We refer to them as the bronchial tree because they look like this. There's a tree branch where you see a big proximal branch, and as you get more distal, the branches get smaller and smaller and smaller until you reach a leaf. And that's why it's similar. As the bronchial tree branches, instead of leaves at the end, we have alveoli. We inhale air through the nasal and oral cavities to the pharynx and then to the larynx where the vocal folds are. Where are the vocal folds? They're deep to the laryngeal prominence. We call these the upper airways. The trachea and then bronchial tree, where there's successive 10 to 23 generations of branching before reaching the alveoli, those are the lower airways. In other words, upper airways are above the vocal folds, and if infected, result in an upper respiratory infection. Lower airways are below the vocal folds, and they can result in a lower respiratory infection. The trachea starts at the larynx, and then as it descends, we see these C-shaped cartilaginous rings of hyaline cartilage. These rings prevent the collapse of airways, especially during exhalation, and they're flexible for swallowing and movement. Descending down to the bottom of the trachea, that's the carina. It's at the level of the sternal angle. It's an internal ridge of cartilage, and it branches into left and right primary bronchi. It's an important imaging landmark, and it's a very sensitive area that, if it's hit, triggers the cough reflex. In this axial section through C7 vertebra, we see the trachea, and in front, the thyroid gland, and behind, the esophagus. The C-shaped cartilaginous ring is bounded posteriorly by the trachealis muscle, smooth muscle under autonomic innervation, and that if the esophagus has food, swallowing this bolus of food moving down, it can push in the back of the trachea so you can breathe and swallow at the same time. Let's review airways. The primary bronchi, or main stem bronchi, branch off the trachea into right and left lungs. The right primary bronchus is wider, shorter, and more vertical than the left, which is why it's more common a site for aspirated objects. Inhaled objects in the trachea, it's like the game Plinko. Remember this? Ding, 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 ding. Inhale this object. Where does it go, down the right or the left? Well, it goes down the right primary bronchus because it's more vertical, shorter, and wider than the left. In this chest x-ray, there's an aspirated dental crown. There it is. And notice there's the right primary bronchus. The left primary bronchus is more narrow, longer, and horizontal than the right. And the primary bronchi or main stem bronchi supply, respectively, an entire lung. Secondary bronchi branch off primary and supply each lobe. That's why they're called lobar bronchi. There are 3 secondary bronchi on the right for the superior, middle, and inferior lobes, and 2 secondary bronchi on the left for the superior and inferior lobes. Secondary or lobar bronchi. Next are tertiary bronchi, which branch off secondary bronchi to supply bronchopulmonary segments. This is why we also call them segmental bronchi. And bronchopulmonary segments supply each segment in each lobe. A few more things about airways. What is the difference between a bronchus and a bronchiole? Some airways have cartilage, some do not. Bronchi are airways lined with cartilage. This is a physical structure that helps prevent the collapse of airways when we exhale. The airways without cartilage, those are called bronchioles. What's the difference between conducting and respiratory airways? Some airways do not have alveoli. Some have alveoli. Conducting airways, there's no gas exchange can occur because of the lack of alveoli. This is how we warm, clean, and moisten inspired air. But this is dead space, airways where air is conducted, but no gas exchange occurs. There's oxygen in the conducting airways, but it's wasted because it is not in contact with blood. Now, in contrast, respiratory airways, yes, gas exchange occurs because of the alveoli. This is how oxygen enters the blood and CO2 leaves the blood and enters the alveoli. What's the histology of the airways? Well, the trachea and bronchi are lined by respiratory epithelium, also called pseudostratified ciliated columnar epithelium. Yes, I prefer respiratory epithelium as well. And like all epithelium, it's anchored to a basement membrane, with loose connective tissue and capillaries below it, or deep to it. There's the basal and apical surface of this epithelium, and the apical surface is in contact with the air. It looks like in respiratory epithelium, like there's multiple layers of cells, but if we outline each of those cells, what we see is that each cell is anchored to the basement membrane, so it's falsely stratified, pseudo-stratified. There are cilia on the apical surface that help move mucus towards the oral cavity. Let's do that again. Here are some ciliated columnar cells, the cilia on the apical surface, and there's a goblet cell that makes mucus. Boom. And we inhale dust particles that, like flies on flypaper, stick in the mucus. And then look at that. The cilia move the dust and the mucus towards the oral cavity, where you either swallow it or spit it out. As we descend down the airways more distally, watch how the respiratory epithelium gets lower and lower until we get to become simple columnar epithelium. And then as we go more distal, simple cuboidal epithelium until the alveolus. And now in the alveoli, that's the simple squamous epithelium. Alveoli, that's next. Alveolus is singular, alveoli is plural. That's the functional unit of the respiratory system. This is where gas exchange occurs. And there's about 300 to 500 million alveoli in each lung, lined by a bunch of cells. Let's go through them. The first is a type 1 pneumocyte, the yellow cells that you see in the illustration. Pneumo means air, cyte means cell. It's also called a type 1 alveolar cell. Simple squamous epithelium that's 25 nanometers thick, or thin, as you will. It facilitates the gas exchange of CO2 into the alveolus and O2 into the blood. There is the pulmonary capillary, lined by endothelial cells. Endothelial cells line the pulmonary capillaries, and they form the vascular side of this blood-air barrier. It's also where the ACE enzyme is located, angiotensin-converting enzyme. This enzyme converts angiotensin 1 into angiotensin 2. It's part of the RAS system. The shared basement membrane between the type 1 pneumocytes and endothelial cells is located there, and it contains loose connective tissue, wisps of collagen and elastin synthesized by fibroblast cells. Type 2 pneumocytes, or type 2 alveolar cells, are cuboidal epithelium with lamellar bodies, those circles inside the type 2 pneumocyte. It produces and secretes surfactant that lines the internal surface of our alveoli, which reduces surface tension within the alveoli and prevents the alveoli from collapsing during exhalation. Cartilage does it on the large airways, surfactant on the smaller airways. The black arrows show a couple of type 2 pneumocytes, and the white circles in size are lamellar bodies with surfactant. Alveolar macrophages are also called dust cells or heart failure cells, and they phagocytize microbes and particulate matter, like dust, and they're derived from macrophages. There are 5 alveolar macrophages, and you see all that particulate matter. This is why we call them dust cells. Here's another micrograph, and you see all those. This is a lower view, but look at all those cells. They're filled with hemosiderin from a bunch of red blood cells after this patient had left-sided heart failure. This is why they're also called heart failure or heart attack cells. The blood-air barrier is the interface between type 1 pneumocytes, fused basement membranes, and endothelial cells. It's what allows the rapid diffusion of O2 and CO2 between air and blood. The layers are as follows: surfactant, type 1 pneumocyte, the shared basement membrane with the endothelial cell, and that's it. So the pulmonary capillary has the blood and the alveolus has the air. Blood-air barrier, and it's very thin, like about 1 micrometer thick. This enables the rapid diffusion of O2 and CO2. That human hair is 120 micrometers wide, and the blood-air barrier, 1 micrometer thick, wide, however you want to put it. Nature is incredible. There is showing, this micrograph is showing an alveolus above and below the blood-air barrier. There's a type 1 pneumocyte and endothelial cell nucleus. I guessed at which is which, because they both look the same. But we know they're there because that's the blood-air barrier. This is the picture I've been using, but it doesn't really show what this micrograph shows. That is better. Alveolus above and below the pulmonary capillary, and that is the blood-air barrier. In pneumonia, It's when our alveoli fill with pus, fluid, and microorganisms. It impairs gas exchange because it increases the diffusion distance for O2 and CO2 and reduces the surface area available for gas exchange. This is showing a healthy alveolus with normal blood-air barrier. That's pneumonia. Look how the pus, fluid, and microorganisms increase the distance for the gas exchange to occur. There's a healthy chest x-ray. There's one with pneumonia. Here's a healthy chest x-ray. Here's one with pneumonia. You see all these airways fill with pus, so much so that you can see them making consolidations in a chest x-ray. That is showing, my friends, alveoli in a nutshell. Next is the vasculature of the lungs. There are two different blood supplies. The pulmonary circulation, one that you're most likely familiar with, is the circulation of blood between the heart and the lungs. But the bronchial blood flow, this is supplying the nutrients to the airways. Let's start with pulmonary circulation. The pulmonary arteries, PA, that's transporting deoxygenated blood from the right ventricle to the lungs. It's the only artery in the adult that's transporting deoxygenated blood. How I like to remember is arteries take blood away, A for away. Why are we taking blood away from the heart? We got to get to the lungs to get rid of the CO2 and to pick up the oxygen. In this anterior view of the heart, there's the right ventricle, the pulmonary trunk, and the pulmonary arteries, and shing, there's blood going out. Now, you see how the pulmonary trunk does that? I always think safe, like something you'd see in a baseball game. That's what it looks like in like the illustrations and in the heart, and it also what it looks like safe in an axial CT, the pulmonary trunk becoming the pulmonary arteries. There's also the ascending and descending aorta as reference. The pulmonary arteries take blood away from the heart to the lungs, and that's deoxygenated blood. CO2 then diffuses into the alveolus that we exhale, and the oxygen that you inhale diffuses into the pulmonary capillaries. So now oxygenated blood returns from the lungs to the left atrium via the pulmonary veins. They're transporting the oxygenated blood, and it's the only vein in the adult that transports oxygenated blood. All the other systemic veins are transporting deoxygenated blood. In review, blood goes from the right ventricle to the lungs back to the left atrium. Heart, lungs, heart. That's the pulmonary circulation. The next is the bronchial blood flow supplying nutrients to the airways. Trachea, right and left primary bronchus, and behind is the esophagus, and the aorta gives rise to the bronchial arteries that parallel the bronchi, the airways. In this medial view of the right lung, there's the bronchus, and take a look at the bronchial arteries. And there's a bronchiole, and there is the bronchial artery supplying oxygenated blood and nutrients to the cartilage and smooth muscle of the airway. Deoxygenated blood and wastes exit via the bronchial veins. Now notice that bronchial vein is deoxygenated blood dumping into the oxygenated pulmonary vein. This creates a small physiologic right to left shunt. This is what slightly lowers the oxygen content in the pulmonary veins, returning blood to the left atrium. Some bronchial veins drain into the azygous system of veins that goes into the right atrium, but most bronchial veins drain into the pulmonary veins, some into the azygous system. In a nutshell, pulmonary circulation is responsible for the gas exchange at the blood-air barrier. Bronchial blood flow supplies nutrients to the airways. The lymphatics of the lungs. There's the airways that shows trachea and primary bronchi. The lungs have two main lymphatic plexuses. The superficial plexus, also known as the subpleural because it's deep to the visceral pleura, and the deep plexuses that parallel the airways. Both plexuses drain towards the hilar nodes and tracheobronchial nodes, and tumors spread towards the hilum before reaching systemic lymph nodes. The lymph continues to drain up the paratracheal nodes, and lymph from the right lung drains into the right lymphatic duct. Lymph from the left lung drains into the thoracic lymphatic duct. And there we have lymphatics of the lungs in a nutshell. Muscles of respiration is next. The diaphragm, well, that's the primary muscle of the respiratory system, and it's dome-shaped, and it's located in and surface anatomy just below the nipple lines. And the lungs are on top of the diaphragm. Now, the diaphragm in this chest x-ray is shown there, with the right hemidiaphragm being a bit higher because of the liver, and the left hemidiaphragm is lower. And you can, if you look below it, there's always this gastric gas bubble. That's a belch waiting to happen. The diaphragm is a skeletal muscle, so it has the following attachments in this inferior view: the internal surface of the xiphoid process, costal margins, and the lumbar vertebrae via the right crus and the left crus. Crus means legs because that's what they look like. All the muscle fibers radiate internally to insert on the central tendon. Muscles are on the outside, or muscle fibers are on the outside, the central tendons on the inside. And the diaphragm has the following openings to allow communication between the abdominal and thoracic cavities: the caval hiatus at the T8 vertebral level for the inferior vena cava and right phrenic nerve; the esophageal hiatus, T10 vertebral level for the esophagus and anterior and posterior vagal trunks; the aortic hiatus at the T12 vertebral level for the aorta and the thoracic lymphatic duct. The functions of the diaphragm: it's the primary muscle of respiration. So inhalation, the diaphragm contracts, increasing thoracic volume. This is active. But exhalation, the diaphragm relaxes. This reduces the thoracic volume. It's passive. The diaphragm is like playing with a parachute, like in elementary school. And when you pull on it, it gets flat. And then you raise your arms up and it's dome shaped, and you bring it flat, and then you put it dome shaped. Now, I mention this because that dome diaphragm is like the central tendon, and the children on the outside are the muscle fibers. So when the muscle fibers contract, look, the central tendon becomes flat, or the diaphragm becomes flat. When you relax the muscle fibers, the central tendon becomes dome-shaped and it's relaxed. Contracted, relaxed. Let's now add the lungs on top, and with a negative intrapleural pressure, whenever the diaphragm contracts, notice the lungs expand because they're sucked, and they keep with the movement of the diaphragm. That's an active contracted diaphragm. Now, when the diaphragm relaxes, it's passive, and when it relaxes, it goes dome-shaped again. So when you contract, air comes in. When you relax, air goes out. When you contract, air comes in. This is why it's called negative pressure ventilation, because when the diaphragm contracts, the negative transmural pressure of the intrapleural pressure causes the lungs to expand. They get bigger, and it sucks air in. Negative pressure ventilation. Much like this, like bellows, and it sucks air in. That's the analogy of negative pressure ventilation of the respiratory system. The diaphragm is innervated by the phrenic nerve. The right phrenic nerve innervates the right hemidiaphragm, and the left phrenic nerve the left hemidiaphragm, like this. See, it goes dome-shaped, then flat. Now let's say that through iatrogenic injury, like cutting it during surgery, or a tumor invades this right phrenic nerve. Watch what happens when you fire action potentials down both the right and left phrenic nerve. You see that? Only the left phrenic nerve fires, and the right phrenic nerve is stopped. And so look, the left hemidiaphragm contracts, but what's going on with that right hemidiaphragm? The contraction of the healthy hemidiaphragm creates still the negative pressure in the thoracic cavity. This causes the upward movement, the paradoxical movement, because it's opposite of what the diaphragm normally does during breathing. But it's this negative intrathoracic pressure that pulls the denervated, paralyzed hemidiaphragm up, and this is what gives this paradoxical movement. Now, what are accessory muscles of respiration? They're muscles that are not normally used during quiet breathing. They're recruited during forced or labored respiration, like you'd have in anaerobic respiration. Basically, any muscle that attaches to the ribs, because when the ribs move, the lungs follow. But it's important to note that accessory muscles are insufficient to provide the movement of air in and out if the diaphragm is paralyzed. Forced inspiration is caused by muscles that increase intrathoracic volume, like that, increasing that volume. external intercostal muscles, the pectoralis major and minor and serratus anterior muscles, the anterior, middle, and posterior scalene muscles, and sternocleidomastoid. All of those, when they contract, help increase the intrathoracic volume. In contrast, forced expiration are muscles that decrease intrathoracic volume, like our external, internal, oblique muscles and transverse abdominis and rectus abdominis bilaterally. Forced inhalation, forced exhalation, forced inhalation, forced exhalation. The forced inhalation, you see the flattened, contracted diaphragm, that downward blue arrow. That pushes abdominal contents down. The outward blue arrows are showing the accessory respiratory muscles like external intercostal, serratus anterior. They expand the rib cage, which increases the volume of the thoracic cavity, sucking more air in from the atmosphere, is what happens. Now, forced exhalation is the abdominal wall muscles, rectus abdominis, external, internal, oblique, pull the rib cage strongly downward, those down blue arrows, which pushes abdominal contents up against the relaxed diaphragm, that upward blue arrow, decreasing the volume of the thoracic cavity, forcing air out of the lungs. Those are the muscles of respiration. Now, the nerves of the respiratory system. Let's begin with the phrenic nerve. The phrenic nerve is mixed. It has both motor and sensory components that arise from the C3, C4, and C5 spinal cord level. C3, 4, and 5 keep the diaphragm alive. The cell bodies of these lower motor neurons arise from the ventral horn gray matter and through the cervical plexus form the phrenic nerve and descend to the diaphragm. When the phrenic nerve fires, the diaphragm contracts. So an action potential firing down the phrenic nerve causes the diaphragm to contract. But clinically, if we have an upper cervical cord injury, this can cause paralysis of our diaphragm. As demonstrated, Christopher Reeve was the actor who played the Superman of my childhood days. And in, I think it was 1995, he was bucked off his horse and he fell on his head and fractured his C1, C2 vertebrae that severed his upper cervical cord. This then caused him to be paralyzed from the neck down, including his phrenic nerve. And because the phrenic nerve was paralyzed, he then relied on positive pressure ventilation the rest of his life. Now, what does that mean? That means that a ventilator has positive pressure that forces air into his lungs, positive pressure that's forcing oxygen into his lungs to allow him to breathe. This is in contrast to negative pressure ventilation that I described earlier. High cervical spinal cord injuries can result in diaphragm paralysis and require lifetime positive pressure ventilation. The phrenic nerve also has sensory components. It's somatic, which is pain, temperature, touch. Now, why am I mentioning this? Well, the pleura and diaphragm and the peritoneum have sensation. Mediastinal pleura sends its sensation, and diaphragmatic pleura sends sensation to the phrenic nerve, as also in the abdominal cavity, diaphragmatic parietal peritoneum. Now, we rarely actually think of this because rarely does you have pain sensation in these regions until you do. That is showing a consolidation in the right lung, which irritates the mediastinal pleura. Therefore, the phrenic nerve transmits this pain sensation to the cervical cord. And the cervical plexus that's supplying the phrenic nerve also supplies the C3, C4, and C5 dermatomes. Therefore, the brain interprets the pain coming from the mediastinal pleura as coming from the right shoulder, referred pain in that area. This is why pneumonia in the thoracic cavity or gallstones in the abdominal cavity can present with right shoulder pain. I showed it on the right. This also happens on the left. Intercostal nerves. Their motor component is the intercostal muscles. The intercostal nerves innervate the external intercostal for accessory inhalation, internal intercostal for expiration, and the innermost intercostal, it really doesn't do much for breathing. It just tightens the intercostal space for attachment of the costal pleura. The intercostal nerves also have a sensory somatic component, pain, temperature, touch. This receives sensation from the costal pleura and overlying skin or dermatome. There's a lung and the costal pleura, and there is an intercostal nerve. Notice that somatic sensation from the costal pleura going into that intercostal nerve, as well as the overlying dermatome. Pleurisy is inflammation of the pleura, friction, rub between the pleural layers that causes sharp chest pain. There are the intercostal nerves, and there is the lung with its costal pleura. Let's say that we have pleurisy of inflammation of those three intercostal nerves. Therefore, there is sharp localized pain that follows the same dermatomal distribution, in this case T3, T4, and T5. It's sharp. How about autonomic innervation of our respiratory system? The sympathetic innervation causes bronchodilation. The smooth muscle lining the airways has beta-2 adrenergic receptors. Our adrenal medulla from the adrenal gland is comprised of chromaffin cells that produce and secrete the catecholamine epinephrine that flows in the blood. And when epinephrine binds to beta-2 adrenergic receptors, shing, it causes bronchodilation. A little anatomy note. Most anatomy books state that direct sympathetic innervation by cardiopulmonary splanchnic nerves via norepinephrine causes bronchodilation. That's not really true. Norepinephrine has very little effect on beta-2 receptors. It's the circulating epinephrine that has the greatest effect. The parasympathetic innervation causes bronchoconstriction and glandular secretion. It arises from the medulla oblongata in the dorsal vagal nucleus, and the vagus nerve, cranial nerve 10, transports the parasympathetic innervation to the muscle in the airway. Now, as we get closer, notice that the smooth muscle of the airway also has M3 cholinergic receptors. So you have both beta-2 adrenergic and M3 cholinergic. And when acetylcholine binds to the M3 receptor, shing, you get bronchoconstriction and an increase of glandular secretion. And that, my friends, is the respiratory system in a nutshell.